Assalamu alaikum. Welcome everyone on board. We will just continue our discussion uh, on this opioid-free anesthesia, which we started 2 days ago. So actually, the basic concept behind doing this opioid-free anesthesia, as we discussed, that there are so many problems which are associated with use of opioids. I will just quickly try to just have a review, quick review, PONV, respiratory, depression, then ileus, then some immunological problems, okay, uh, post-operative cognitive dysfunction, especially in elderly patients, okay, and another thing which is actually may not be associated in a way that opioids are closely strictly controlled, but actually it was labeled as opioid crisis because there was so much data that opioid misuse was associated with a lot of problems, um, which you open the door when you are using as an like anesthetic agent. So there are a lot of problems which are associated with it. Okay, so in our preceding discussions, we just touched different points that what are the reason for it, and then we actually, because the problem is that when opioids were introduced, the advantage was that they are giving a very good balanced and hemodynamic conditions, and they were used in even in the patients which had limited cardiac functions. Okay, so that was the selling point of opioids. But the problems which were associated were maybe sometimes were overlooked, or you can say were like they were accepted as unavoidable things. But as soon as other agents, use of other agents came in, more when people started becoming more familiar with these things. Actually, ultimately, what has happened that now it's a new domain. But the problem is that it is not everyone is familiar with this mode. Then another thing still, because not good research work, and not everyone is familiar with this technique, because if you are using whatever opioid is available in your hospital, if you are using it, it's just like even with the closed eyes and closed mind, you can use them like a robot. Okay, because everyone knows it and everyone is familiar with it, and you're just doing a routine work. So this needs attention, because if, for example, you start using these agents blindly, other agents which we just discussed, some of them, lidocaine and dexmedetomidine, we discussed yesterday. Okay, I have personal experience with both of them, and ketamine and magnesium sulfate. Okay. Like I have used these three agents personally, these two agents in infusion form, and this mainly in small dose of around, you can say, 0.25 to zero point 0.5 milligram per kg, but not in infusion. Magnesium sulfate, I have limited experience. There are so many people who are using it like lidocaine, but I don't have personal experience. But wherever we find the concept of opioid-free anesthesia, then the most important thing which we have to follow is the use of multimodal analgesia anesthesia concept with paracetamol and NSAIDs, whenever possible, local anesthetics. Okay. Whatever mode you can use, either in the form of some blocks, either in the form of local infiltration, or in the form of central neuraxial block. Whatever is feasible according to that surgery, you have to uh, you have to use it. Just a second. Okay, so because if you use these medications blindly, then maybe you can face, like, for example, I will just, yesterday we were discussing dexmedetomidine, And actually we had a controversy that it was written that it increase ileus. Actually it I just checked a number of sources. It is wrong, because theoretically it is sympatholytic. Okay, so anything which is sympatholytic will not cause ileus. It is the other way around. Okay, so dexmedetomidine does not cause ileus. And sorry, another medication in addition to the use of this paracetamol, I again write it here, NSAIDs, okay, local anesthetics is another background thing which we actually don't consider as analgesic, but in my book, in my concept, it is a wonderful analgesic. Okay, we don't use it with the concept of we are using it for PUNV, we are using it for and as anti-inflammatory, but reality is that uh, dexamethasone has anti-inflammatory action. And if you just consider the basic concept of pain pathway, okay, so the transduction, transmission, modulation, and perception. Okay, so if whenever you are giving an anesthesia, and whenever you are trying to have a multimodal anesthesia concept, and even because this is very important, because by giving opioid, actually you are bypassing everything. You are attacking mainly in perception. uh, I just fail to understand what is the mechanism of opioid mediated somatic pain relief, because I don't think so. It should have a very good somatic pain relief. Okay. But actually, because it controls the perception, and it has also effect on modulation. So actually, we are not able to perceive the pain. The pain is there, but we are not feeling it. There is end result, we are controlling it. Okay, so that is the main use of opiates. So that's what I just wanted to tell you, that you should be using these, you make these. And another thing, I repeated, I told this thing last time as well, I will just repeat it. Try to have local anesthesia infiltration at the site of surgery before incision. If you have given a central neuraxial block, or if you have given a compartment block, you can just think what is in your head. You can have central neuraxial block, compartment block, peripheral nerve block. If you cannot do all these three things, please request talk to the surgeon and convince him to have local infiltration before they give the incision, and you will see a big difference. Then another thing, like I told yesterday, that in ERCP, try to have gargles, a lot of gargles, okay, with lidocaine. Like you can say you can use the lidocaine spray, and the advantage will be that I have used personally. And if you are using this lidocaine as gargles, because what happens that usually they are doing this procedure with local when they are not doing it under general anesthesia. Okay. But when they are doing under general anesthesia, they don't use it, because in their opinion, now the patient is knocked down with the general anesthesia, so you don't need to give it. But I think it's very important. Similarly, if you are doing any anal procedure, or like it the same go the like colonoscopy. Okay, just try to anesthetize this area. And what the even the urological endoscopy, what they do, they they put the jelly as a lubricant, not as a local anesthetic. So my request to all of you is that try to use lidocaine. Try to use lidocaine jelly, not as a jelly only, not as a lubricant only. Try to give enough time. You can, maybe you can give it and relax them for few seconds. Tell them that let this medication takes its effect before you proceed. Because what they do, they just put the jelly, and the next second they have put inside. Okay, so if you want to decrease the stress response at that time, try to use local anesthesia as much as possible. Okay, so similarly, of course, there will be certain conditions which will you not be using it. Okay, so today we will discuss few points about ketamine. Okay, everyone is afraid of ketamine, that it will cause increase in heart rate, and increase in blood pressure, and it will increase the secretions. Okay. What else? Increase in pulmonary artery pressure. Okay. Increase in systemic vascular resistance. There are so many things which are documented as a bad points about ketamine. But practically, if you are these things are occurring only if you are using in a higher dose and like repeated dose, you can say. Otherwise, if you are using in a slow infusion and you are using in that the dose which I told you around 0.25 to zero point 0.5 milligram per kg, okay, what are the advantages you are getting? You are getting a very good analgesia, okay. And then there is if especially if you are using already you are using opioids, there is an effect which is called as opioids induced hyperalgesia. Opioid induced hyperalgesia, and it is a known documented fact that ketamine, via its effect on NMDA receptors, okay, it controls or it prevents this opioid induced hyperalgesia. Okay, opioid induced hyperalgesia. And actually, because opioids, they have so many paradoxical effects. One is opioid induced tolerance. Of course, this will be not in do you know the concept of opioid nave? Anyone knows about it? What do you mean by opioid nave? Anyone knows about it?
Opiate naive means
Okay,
जो बंदा अभी तक whoever
you
is
have
not
not
exposed
exposed.
to the
Okay, so there will be different response in a patient who has never received opioids, opioid addict. Okay, like there will be different patient who will respond to if opioids in a different way. Like why I'm so sick of opioids, I myself has a very bad experience. I was bitten by scorpion and I received a very terrible opioid, which in international standards is not a pure opioid. That is, I shared before as well, nalbuphine, which is actually an opioid agonist antagonist. And I had such a beautiful euphoria that I was enjoying my life. I didn't don't I had a pain, but I was not feeling it. So that day I understand how much addicts enjoy their life. Okay. So that's why this is the concept that you should have in your mind whenever you are using opioid, that there are some unwanted effects which you can avoid by using other medication. So ketamine, as I told you, if it is used in small dose, it has so many advantages. Like in this dose, if you go to pediatric anesthesia, especially pediatric cardiac anesthesia, that even they are using it for something more than this one, and it is they are using it for induction in majority because no other medication is safe in those very tiny pediatric patients. And in books we see something else. I have worked 2 years in cardiac anesthesia, and actually the safest drug in those patients, even with having complex congenital heart disease, the drug of choice was ketamine. So because it was giving such a beautiful coverage, it was being used. So actually, ketamine use is another important point which people miss, and even I did not believe for some time. All of us think that midazolam, okay? Everyone thinks that whenever we are giving ketamine anesthesia, we have to use midazolam, okay? So remember one thing, that midazolam itself is a risk factor for delirium. And you will be surprised that if you have used low dose ketamine, it actually is prevention of delirium. You can reconfirm this thing in the text. Okay. So midazolam use itself is a risk factor for delirium. And ketamine use in your anesthesia regime, this was our MCQ in theory. Yes. Okay. So this is, remember this point, that sometimes we don't remember this thing. So this is very important thing. So ketamine is being used, and you can use, because I told you that again, not everyone is using it. So there are so many ifs and buts about it. but I use indifferently. I have not used ketamine as an infusion, but I have used it as an adjunct. Like for example, if I am using dexmedetomidine, okay, and the problem with dexmedetomidine is that if you are yesterday I discussed that if you are going giving in the doses which is written in the books, unfortunately, maybe you will face problems. I don't know which patient population they have created that data. I think in my opinion, because in majority of patients where they have decided this dose, it is being used as a sole agent. Okay, but if you are using in our anesthesia practice, in which you have given propofol, you have given muscle relaxant, you have given other medications, you are giving sevoflurane or whatever you as well. Now, if you want to introduce this as a background music, you should not give it in a high dose. Okay, you should give it in a very dose. And in my believe me, I will be surprised that my personal experience that even 0.1 to 0.2 microgram per kg over a defined period, whatever it may be the requirement will be more or requirement will be less, but I never try 1 microgram per kg, because even with this dose which I give, sometimes the heart rate comes from 80 to even 50, 55, 54. Okay, so never try to give this dose. I will never suggest anyone who is using as a like not have enough experience, because I face that. And then another problem, that if you use dexmedetomidine a lot, there will be delayed recovery. The pattern of delayed recovery with dexmedetomidine will be different from opiates. The problem will be here that patient will be sleeping without any, even if you extubate, there will be in majority of cases, if there is no other risk factor, maybe patient will be kept on sleeping, not, but there will be no respiratory depression. Okay, so the breathing pattern will be fine, but the patient will not be awake. Okay, so this is the problem which you should be thinking. Similarly with ketamine, if you have given in a lot of dose, then maybe there will be increase in secretions. Okay, and then the unwanted problems can occur. But usually in the low dose, I many times I just give a very small dose, maybe 10 milligram, maybe 20 milligram, maybe 5 milligram, and I just enjoy the effect because heart rate start going down, because I have given use a very small dose in a very tactful way. Because before, when I was in, unfortunately, in our training, in our setups, sometimes we are giving 200 milligram, 50, 50, 50, 50, and we are doing a whole case with ketamine. And then I had very terrible stories with ketamine. But now I'm utilizing ketamine in a totally different way. Okay. So this thing you should be knowing that ketamine all has central effects. Ketamine has effects on NMD receptors. Ketamine has effects on thalamus. Okay, and ketamine has effect on opioid-induced hyperalgesia. So if you are using ketamine along with other medications, like you have even lidocaine, you can use a combination. Like I, majority of time, I'm using combination of these three medications: ketamine, lidocaine, and dexmedetomidine, and it's a wonderful experience for me. And even because about dexmedetomidine, I told you that dexmedetomidine sometimes people are even given in spinal as intrathecal, 5 to 10 mics of Presidex in spinal intrathecal. Okay, that, but then I read about it that Presidex, or even this is true for dexamethasone as well, that if you have given any block and you have given dexmedetomidine or dexamethasone, even in any other route, the effect and quality of the block will be prolonged. I repeat, if you have used local anesthetic block and you have used dexamethasone or dexmedetomidine, the quality the block and duration will be increased. Okay, so because whenever you are using intrathecal, the problem is with the preservatives. So ideally, either that preservative which are being used should not have any problem with the CSF, or they should be preservative free. Okay, so this is difficult, and unfortunately, if you give it, there is no guarantee that it will be safe. So it is not advisable to use unless you are, yes, it's not licensed, but it is being used. Okay, It is not licensed, but it is used frequently. All majority part of the world, they are using it. Okay. Even in Pakistan, even in my hospital where I'm working, there are few anesthetists which are using it. I used only 1 or 2 times, but then I read about it that dexmedetomidine, even if you are using in IV form, like you have given spinal, and now you want to sedate a little bit, try to use dexmedetomidine. It will give a wonderful experience because it will give you a very good anxiolysis. It will sedate the patient. It will calm the patient. The chances of post-operative delirium will be reduced. Yes, of course, you have to look at the hemodynamics. There is no question that you use. I have read from here somewhere, and I have this, and now you am using it without any understanding. Okay, because these medications still not not acceptable and not used by everyone. Okay, so that's what I am starting to think this thing, that opioid free anesthesia, there are still not enough data available in all patient groups, in all surgical procedures. Okay, in all age groups. Okay, so that everyone can use it blindly. Okay, but you can try one by one, you can make a combination. Okay, so some points about this is because ketamine, there is a lot of things about ketamine, but like with reference to opiate free anesthesia and with reference to use as analgesic, these were the few points. Magnesium sulfate, actually, what effects, if you have a patient who is receiving magnesium sulfate, it has vasodilator effect via effect on smooth muscles. It has sympatholytic effect. Okay, it has membrane stabilizing effect. So these effects are actually helping in almost a similar way, not like lidocaine. Okay. So, but what are the problems with magnesium sulfate? You should be knowing that magnesium sulfate will increase the neuromuscular blocker effect. Number one. Number two, if there is no renal output, like renal function, urine output is not there, or renal kidney functions are not good, magnesium sulfate can cause toxicity. Okay, so that the same sequence of tendon reflexes, then respiratory problem, and then cardiac problem. I'm not going in details because we have few minutes left. So I'm just giving you an idea that if you are using magnesium sulfate, should be ready for these things. Okay, so like you should not use magnesium sulfate if there is no urine out. It can create toxicity. Okay, and again, the dose will be around 10 to 15 milligram, I think, 10 to 15 milligram per kg per hour, I think. Because I don't remember, I don't have personal experience, but magnesium sulfate people are using just like lidocaine infusion. Okay, I have like discussed with many people who are using magnesium sulfate for this purpose. Maybe in coming days, maybe I will try it. But actually, still, I'm like you can say, it's only few years since I changed my approach about giving anesthesia. But these are the main points about magnesium sulfate. Okay, so magnesium sulfate, again, you should be giving in infusion. Like you should, again, the concept again, before finishing, I will tell you that opiate-free anesthesia or opiate-sparing anesthesia is a wonderful technique, but it needs attention. It needs personalized plan for each patient. Like you cannot make a default plan and you can use it in every patient. Okay. But like as much experience I am doing it, like for many months, you can say I have almost deleted use of opiates. Okay. So this is one of the topic which can be asked in your exam. Okay. Oral, like there is one part of a question among topics which are relatively, you can say, rare. So I will just name like TIVA, TCI. Okay. This opioid free anesthesia or opioid sparing anesthesia. There are some other techniques like low flow anesthesia. You can find a number of topics like that. Okay, like recent developing things. In every exam there is at least one component of such things. So any questions, any comments?
Assalamualaikum, sir.
Walaikum assalam. Yes.
Sir, I would recommend that a follow-up to this opioid-free anesthesia. We can perform anesthesia. The surgery is usually of 1 hour, 2 hour, 4 hours. But what about the post-operative period? The
Very
surgeons
good.
usually give opioids in the post-operative period, so we have to continue that opioid-free regime
Yeah.
for the patient throughout his hospital stay. So I
Yes, you are
think
absolutely right.
further talk is needed, maybe 1 or 2 sessions on that also.
Yeah, actually, Zishan, the problem is that you are absolutely right. The thing is that these things which you do intraoperatively, unfortunately, with these agents, it is very difficult to have post-operative period covered in this regime. But actually there are some and there are some setups in which they are using even in ICUs lidocaine infusion. You are absolutely right. But actually, you know what was happening? That if you have given local anesthetic infiltration or block, you are reducing the requirement. Yes, of course, post-operative plan should be there. Okay, so that's why I'm telling you that a lot of effort is needed to use it. Because I tell you something, like if you have a long surgery, usually in even in the setups where paracetamol and NSAID is available, they are usually not giving it. There is a, I don't know, reluctance to give it. For paracetamol, I always listen from a majority people, we will give it in the post-op. It's no problem. You can give it in the post-op as well. Why are you denying the patient of paracetamol in the anesthesia period? So similar plan, you can have some individualized plan. Of course, you cannot put a magnesium sulfate infusion or lidocaine infusion or Presidex infusion and give it to the surgeon. It's not possible. That's why that is a limitation of this opioid free anesthesia. But at least for the intraoperative period, you can decrease the requirement. This is one thing. The immediate postoperative period, the requirement will be like what I do, because the intraoperative period I can monitor and I can give the guarantee. So postoperative period I write, because in our hospital the favorite medication in postop period is pethidine. So pethidine is being used like anything, like coffee. So I write it and thank you very much. But I request them that don't give unless the patient is patient is really requiring it. Okay, and usually we repeat paracetamol after 6 hours, at least 6 hours. Okay, but what I do that if I have given paracetamol right in the start of the surgery and even 4 to 5 hours have gone, so I give it and tell them that don't give paracetamol like lex dose, they can adjust accordingly. Because the paracetamol and NSAID, if you have used in a proper way, you have given a good amount of fluid, because this is a whole package. Like for example, if you have given not given opiates and you are hoping that there will be no nausea vomiting, but you have not given a good fluid, there will be still chances of vomiting. Okay, if you have given like nitrous oxide and you have given an inhalational agent, and now you don't have, of course, unfortunately this is facilities not there in Pakistan in all setups, or not in even all hospitals, even not in even Saudi Arabia. Sugamedex is not available in every hospital freely. But believe me, I'm still Sugamedex, there are not competitors which are available in the market. Only one company is making it in the with the name of Viridon. Sugamedex reversal is like anything. It is because there is no problem whatever, and Mercer relaxant, how much you have used, you used reverse it with the Sugamedex like anything. It's like a magic. Okay, because if you have now deleted, like a neostigmine is a big factor for postoperative nausea vomiting. Okay, so if you are giving neostigmine and you are hoping that patient will be absolutely fine, it will not happen. So good fluid management, avoidance of any medication which can cause the that vomiting. So opioid free anesthesia, of course, is a challenging thing. It's not an easy job. Okay, so your point is absolutely valid, and we will inshallah discuss some other aspects about it. Actually, when I was doing Nora, unfortunately, I skipped some of the point about urological surgery. So tomorrow, inshallah, I think I will try to have some points about endoscopic urology. Like we discuss about this ERCP and endoscopy procedures. So I think we did dental procedures. So in coming days, I will just try to have some other procedures which have atypical procedures. We will do later on. I will do ECT, cataract surgery, like that. Okay. So thank you very much, all of you, for your presence. And any question are welcome. Uh, Whenever want to ask any question, you are welcome. Okay. Some people who are appearing in the oral exam, I again invite you. You can drop any question to me anytime. Okay. Sundas, like I think you have exam, so I appreciate if you, like you people, uh, I can have separate session for you people focused on any long case and table viva if you want. Okay, you are welcome. So thank you very much.
Thank you, sir.
Inshallah, uh, we will meet tomorrow. Inshallah, same time. Assalamu alaikum.